We're going to talk about some of the diagnostic testing for oxygenation. First thing I want to talk about is arterial blood gases. And this is probably the most accurate method for determining the patient's actual oxygenation status. There are 5 primary components to the arterial blood gases. The PaCO2, which measures the carbon dioxide in the blood. The normal values are 35 to 45. PaO2, which is measures the oxygen, actual oxygen in the blood. Normal is 80 to 100. Oxygen percent saturation tells us about how much oxygen is attached to the hemoglobin, or how much of the blood is saturated with oxygen. And this gives a static number of 97%, but 95 to 100 is generally considered normal. And depending on disease process, 92 and above might be considered normal. Occasionally, patients with chronic obstructive pulmonary disease, or COPD, or severe lung disease might be considered normal at 90. The pH measures the hydrogen ion concentration, and normal is 7.35 to 7.45. And then the bicarb is a measurement of, helps to measure the acidity versus alkalinity, and normal is 22 to 26. We'll learn more in depth about arterial blood gases when we talk about the actual disease processes of oxygenation, and again, we'll talk about it when we talk about renal function itself. You don't need to memorize these normals yet. You certainly need to start thinking about them, and you should have an idea of what they mean. So if we have an elevated PaCO2, it's typically indicating that the patient is in respiratory acidosis. If we have an elevated bicarb, that typically means that the patient is in metabolic alkalosis. So that's just a good place to start thinking. Typically, you'll see that the PaCO2 will be opposite of the pH in respiratory disorders, meaning that if the pH is high, greater than 7.45, and the patient has a respiratory alkalosis, because anything above 7.45 is alkalinity or alkaline, then the PaCO2 will typically be below 35. Because remember that carbon dioxide is your acid. So in an alkaline environment, we're typically going to have fewer acids, and so we would have a low PaCO2. If the pH is low, less than 7.35, then we would typically see a carbon dioxide level, the PaCO2, greater than 45, indicating that there's a lot of acid in the body, and so the pH would reflect that by being low. So below 7.35 is acidic, and greater than 7.45 is alkalytic. So that's a good place to start for now. Arterial blood gases are obtained by an arterial puncture. Depending on the facility, it might be done by respiratory therapy, It might be done by certain personnel in the laboratory, and sometimes it's done by the LPN or RN who has received special training. Um, so you just need to know what is appropriate in your facility. Now, the chest x-ray is probably the most common uh, oxygenation diagnostic test that is done. Pardon me. It is a radiologic procedure. It's non-invasive and typically the least expensive of any of the diagnostics that can be done. It can give us a good idea of the aeration of the lungs. Typically on x-rays, air shows up as black. Areas of consolidation or fluid buildup or solid tissue or solid masses will show up as white. So as you're looking at this, you can see that the lungs are fully inflated. We've got good aeration. You can see above the clavicles where the lungs are. You can see down to the diaphragm. You can see the outline of the heart, and if you look closely, you can just see a line where the aorta goes down. You can even see where it's marked for the trachea. It's slightly gray, not completely whited out because it is a hollow tube. So you can learn a lot simply by looking at a chest x-ray. General safety measures typically are for the healthcare person. A lung scan is typically when we talk about a lung scan, we're talking about two things that are occurring at one time. It may be one or the other, but a lot of times it's both. So you might see it called a lung ventilation and perfusion scan, or VQ scan. It is a nuclear medicine procedure typically performed in a radiology department, significantly more expensive than a chest x-ray. Its purpose is to assess the ventilation and perfusion of the lungs at the same time. This can tell us that there's a pulmonary embolism or a tumor or fibrosis of the lungs. It can tell us that there are stagnant areas in the lungs, such as in emphysema. It tells us that the alveoli are extra inflated or something like that. So if they're doing ventilation perfusion scan, then the patient will inhale a radioactive substance, and a radioactive substance is injected into the veins. A lot of times our radioactive dyes are iodine based, so again we would ask about allergies to iodine or shellfish. Then the scan is done to compare the equality of the inhaled radioactive compound to the injected radioactive compound. In healthy lungs, there should be a match. In presence of a disease, then there will be a mismatch. So what this example is showing is that there's an obstruction of a pulmonary artery. So the dye that's been injected doesn't go throughout the lung because there's an area that's not being perfused because of the clot. But you can see that the inhaled substance goes in. So this would tell us that indeed the patient does have a pulmonary artery. So in the case of perhaps a tumor that's occluding a bronchial, then it would be the other way around. We would not have what in this picture is depicted as green, but we would have red. And we may even have an area of concentration of red because of the blood supply to the tumor. As a precaution, pregnant patients and pregnant nurses should not be involved in this procedure. Pulmonary function studies are typically performed by respiratory therapy. They're not painful, but they certainly can be tiring, especially for patients who do have pulmonary disease. They're used to determine the volume of air that the lung can hold, the rate of air that can be forced in and out of the lung, and the elasticity or compliance of the lung. And it's the compliance that often will affect the volume of air that the lung can hold and the rate of flow. So we will see that patients with restrictive airflow disease like severe asthma or COPD will be unable to take large volumes of air in. Obstructive disorders, again, like your COPD, which can affect both, then expiration is affected. They're unable to get air out. So it can give us information about progression of a disease and lead us in a direction to best assist the patient to improve or maintain their lung function. Bronchoscopy is done by way of a fiber optic endoscope that's both rigid and flexible. So there's a portion of it that is rigid and a portion that is flexible. It allows for direct inspection and examination of the upper portion of the lower airway. So it allows us to go through the larynx, to visualize the trachea, and to see, like what you're seeing in the bottom picture, is where the right and left mainstem bronchi bifurcate from the trachea. Now, because of the way that the mainstem bronchi lie, most things most easily will go down the right because it has a broader angle, whereas the left is a sharper angle. But the person performing the bronchoscopy has the ability to make it go either direction. So it is useful to examine tissue. Is there a lesion, a polyp? Is there something that we can easily remove? We can take specimens. Well, we can't, but the person performing it can. Remove foreign bodies, diagnose sites of bleeding, and destroy or excise lesions. Consent is required, and that's something that I failed to mention on the lung ventilation perfusion scan. Consent is required because it's an invasive procedure in that we are administering that radioactive material. So bronchoscopy is also considered as an invasive procedure, so we do have to have consent. Sedation is frequently used via IV, and but they often will want them to cough or participate, by turning their head, so they don't sedate them to the point of unconsciousness. So they usually use something that's provides conscious sedation, such as Versed. They do give supplemental oxygen because they are occluding the airway to some extent. So we must provide the patient with the oxygen that they are not receiving. Frequently, they're asked to be NPO 6 hours prior because they could stimulate the gag reflex, and then the patient would possibly vomit. And because their protective mechanisms are dampened because of the sedation, and the epiglottis can't close, the larynx can't close to protect the lungs, there is the risk of aspiration. They are continue to be NPO after the procedure until the gag reflex returns. And those are important nursing considerations to make sure that the gag reflex has returned before giving them food or fluid. Occasionally, patients will have reaction to the anesthesia. They can have bronchospasms because of the irritation to the bronchial tissue. They can aspirate. Excessive bleeding, especially if a biopsy or removal of tissue or foreign body was done. It can perforate the trachea or bronchial walls and cause a pneumothorax. And then, depending on the patient's reaction to the anesthesia, it could cause respiratory arrest because of the sedation. So after the procedure, the nursing functions would be to watch for bleeding, hit the wrong button. Make sure that patients know, excuse me, that we want sputum that comes from the trachea, not just spit, saliva. We want them to rinse their mouth with water prior to producing the specimen, so they should rinse and spit. The early morning is usually the best time to obtain a specimen, but you may, depending on when you get the patient, you may not want to wait till the next day, so you want to try to get them to obtain a specimen as early as possible. Typically, we need a minimum 1 teaspoon in a sterile container. A lot of times it works best to have the patient take a couple of deep breaths and cough forcefully from the chest, not just clear their throat, in order to obtain that specimen. The specimen, once it's obtained, then will be sent to lab where they'll do a culture and sensitivity. The culture can take up to 24 to 48 hours to be able to identify the pathogen. In the meantime, antibiotics might be started while they're waiting on the sensitivity. Sometimes the idea of the pathogen gives us a direction of what antibiotic to anticipate. So the pathogen, the initial culture will say that it's a bacteria, it's a gram-positive or gram-negative, it's a rod, it's a cocci, whatever. And the physician will choose an antibiotic based on that. And then the sensitivity comes back and says, well, this particular bacteria isn't sensitive to that, and so a change in antibiotics might be done. Always obtain the specimen prior Pulse oximetry, most of you are familiar with. It's a non-invasive, inexpensive method of evaluating arterial oxygen saturation. You can get readings from the earlobe, the foot in a neonate, a fingertip. So there's multiple ways that can be used. All of them rely on adequate perfusion. So if a patient is cold, then you're not going to get an accurate reading. You may not get an accurate reading if they have inadequate cardiac output, like in heart failure. Bright light, external or bright hematologic studies or blood studies are also useful for measuring oxygenation or in evaluating oxygenation, I guess. Hemoglobin, which is a portion of the red blood cell, has an affinity for oxygen. It also has an affinity for carbon dioxide, but that's a different story. So the evaluation of the hemoglobin and hematocrit should be part of the respiratory assessment. It gives us an objective means of measuring oxygenation. So what it will tell us is that if the patient has a low hemoglobin, it may not matter how much oxygen we're giving them. The hemoglobin molecule can only hold so much oxygen. So if there aren't enough hemoglobin molecules or there isn't enough red blood cells, then the patient is going to have a low oxygenation. So conditions that cause blood loss, conditions that reduce the number of red blood cells, or conditions that reduce the production of hemoglobin, even though there's adequate numbers of red blood cells, are all going to affect oxygenation.